what are the therapies we have, what are the evidence we have. When we talk about heart failure with reduced ejection fraction, we have many evidence-based medicine, many proven therapy, proven molecules, which not only reduces the morbidity, which not only gives symptomatic improvement, but also reduces mortality in heart failure with reduced ejection fraction patients. So let us see, this is the graph which depicts the major randomized controlled trial right there from 1986, when hydrolyzine and isosorbate dinitrate was used, and it was found to be beneficial as compared to placebo when we consider the Black patients spatially. And in those patients, particularly this molecule, it performed very well. And after that trial, the guidelines, they recommended hydrolyzine and isosorbate dinitrate combination, particularly in Black patients with heart failure. And those patients where AC inhibitor or ARB, or say for that purpose, the ARNI, where all these class, the RAS blocker, when it is contraindicated or it is not tolerated, in those conditions, we can use this combination of hydrolyzine and isosorbate dinitrate. Then in early 90s came many trials where AC inhibitor or ARBs were used, and trials such as SOL-T, SOL-D, and these trials where enalapril was used, and there was significant benefit seen in terms of morbidity as well as mortality reduction in heart failure patients. Then when we talk about beta blocker, of course, we know that long-acting metoprolol, sustained release, as well as bisoprolol and carvedilol, these three molecules in the group of beta blockers, they have strong evidence and big RCTs, which shows significant reduction in mortality and morbidity when used in heart failure in reduced ejection fraction. So then came other trials like SHIFT trial, where ivabradine was used, and it was seen that when in patients with ejection fraction less than 40%, and when the heart rate was more than 70 beats per minute, despite the use of beta blocker in maximally tolerated dose, when we add ivabradine, there is further benefit in terms of morbidity and mortality. Then finally, in 2014, came a very important molecule in the form of ARNI, and the trial which came, the first trial with ARNI was Paradigm Heart Failure trial. This Paradigm Heart Failure trial, it was a landmark trial because it showed such significant benefit with the use of this new molecule ARNI. And the interesting thing is that unlike other trials, previous trials with AC inhibitor or ARBs or beta blocker, here the molecule, the active drug, was compared to another drug which was already established as a therapy in heart failure. And here ARNI was compared with enalapril, and ARNI came out to be significantly better as compared to enalapril in reducing mortality and morbidity in heart failure with reduced ejection fractions. Previous trial, other molecules were all compared with placebo, but this is the trial where both the active group as well as the control group, there were active drugs which were being compared. A brief, small few lines about Paradigm Heart Failure trial. A huge number of patients were taken, around 8,442 patients were randomized to either get ARNI in maximum dose of 200 milligram twice daily, and versus enalapril in a dose of 10 milligram twice daily. It was given on top of standard HFrEF therapy, which excluded AC inhibitor and ARB, except enalapril in the control group. So here we can see that inclusion criteria was NYHA class 2 to 4 patients with ejection fraction of less than 35, and BNP level were elevated in the patient population, and exclusion criteria were history of angioedema, EGFR less than 30, very low blood pressure like systolic blood pressure less than 100 were excluded. And when there was requirement for treatment with both AC and ARB, those patients were excluded. So this was a trial which showed largest mortality and morbidity in patients with HFrEF, and most geographically diverse trial in patients with HFrEF, and most racially diverse trial HFrEF heart failure trial. So paradigm heart failure, say it was the largest trial in patients with HFrEF. So what we see in this landmark trial is that there was significant reduction, 20% relative risk reduction in cardiovascular death, as well as heart failure hospitalization, and overall mortality reduced by almost 16%. So the magnitude of treatment benefit was consistent in patients with and without ICD.